nice to have you around for this brief time so we can talk about the Pride&Joy approach, given the current circumstances and situation around the world. And hopefully we can gain some insights and understanding of what can be done. So
Good morning, Javier. Good to talk to you.
Thank you for joining me.
Good to talk to you.
So, Alex, given the current state of things where we see parts of the world that are approaching or starting to relax some of the conditions of confinement and restrictions of movement of people, and the current load on the healthcare systems, it's starting to come down per COVID. What do you think is a current situation? What are the recommendations as we start to think on the ease of the conditions, provided that we think in terms of the Pride&Joy approach that people have been using at the institutions that you're familiar with?
So thank you, Javier. I mean, clearly there's been some heroic efforts by hospitals and hospital staff during this crisis, and they've had to change many systems and many approaches almost just like that without having the opportunity to think it through, because they've just been meeting patient needs, and that's been the overriding impact. And hopefully we can see the huge effort and reward that these people should get for all the effort they've put in, etc. But what we now need to think about is what's going to happen as people tend to emerge from that crisis, yeah? And emerge, I think, is the right word, because it's not going to be an on-off switch where suddenly everything can go back to the way it was. And what I hope people realize is neither should it go back to the way it was. Actually, this gives us an opportunity to sort of reset and think again about how we run the hospital environment. Because one of the things that's happened throughout this crisis is very clearly there has been a termination or significant reduction of the number of outpatient appointments and a termination or significant reduction of planned surgery environments, yes? So actually this has been capacity that's left over and been given over to the patients with the COVID crisis. So as those numbers start to drop, then we have the simple question of how are we going to rebuild all parts of the hospital simultaneously? Because we need to rebuild the emergency stream so it can deal with the everyday emergencies, but also rebuild outpatient and planned care streams. And it's this second one that gives us a real opportunity to actually take on board some of the principles in my book and think differently about that startup. First of all,
go ahead.
As every bed becomes free, we have that simple question to answer. Of all the patients who I could put through the bed, which ones should I put through the bed? Now, this may seem in the COVID crisis easy, the one who's the sickest. But as we come out of that crisis, we can actually introduce a new criteria into how we go about this. Now, we need some simple data to be able to do this properly. And I emphasize simple. This can actually be a simple approach rather than some of the complicated approaches that we've seen. The first thing we need is simply the size of the backlog. We want to know from each different type of care that's needed, what is the number of patients waiting for that particular type of care, yes? And that will give us some indication of the capacity that we're going to need in order to be able to treat the patients, yes? And that capacity can just be the number of patients multiplied by the average or typical length of stay of patients receiving that form of treatment. Add all that up, and that'll give us the total patient days required, yes?
So we need just basically to understand the sheer magnitude of the demand that we need to actually process or absorb in order to be effective at treating and reducing these now people that have been waiting until the hospitals can return to their usual ways of treating ailments rather than this emergency, right?
Yes, and in fact, what I would say is rather than going back to previous levels of backlog, actually do the calculations as if you were going to try and eliminate all patients waiting for any form of delay. Yes?
Yes.
And base that on the backlogs, the total backlogs that you have per stream of care. Yes? So that's the first thing that we need to do. The second input is some of those are going to be very urgent. There's going to be patients who are actually in pain or even whose life is at risk. And so obviously that's going to be another form of criteria against which we should judge. And those patients inevitably will end up going towards the top of our list. Yes? But then the second thing we should think about is the financial impact. Yeah, and we must think about this simultaneously. Yes. Now, in the book Pride and Joy, I dedicate a whole chapter on understanding how to evaluate the choices between patients. And basically, I show a very simple calculation. It's actually on page 165, if I remember correctly.
To be precise.
Yes. And basically what we do is we look at, well, what's the revenue for each particular type of care? And from that revenue, we subtract what I call the truly variable costs. Now, why I emphasize the word truly variable costs is often people will make the mistake of adding in things like the cost of staff. Yes. Now, that's not going to be varying in our environment. Yes, we're going to take the staff we have and we're going to use them differently or choose the patients that go through them differently. So we actually only need the truly variable costs, the medicines, the bandages and things like that,
Correct.
if you like, a relatively small proportion.
So for practical purposes, all the, let's say, labor and the intensive expenses that are related to the service are usually fixed for all practical purposes, because we're not going to change the staff. We're not going to change how the hospital does the work. What we're going to do is just the consumption of the material and the treatment, not equipment, but consumables, let's say, for each occasion that needs to be taken into account.
And this is what in TOC terms we call the throughput. Yes, so it's the selling price minus those truly variable costs. Yes. And then what we think about is, well, what's going to be the emerging constraint? And of course, the emerging constraint is that free bed that we finally get, yes, that we no longer have the COVID patients in, that we finally get some capacity back, yes? So what we should do is a very simple calculation, which is our selling price minus consumables, yes, or raw materials or variable costs, that we call throughput, divided by the current average length of stay for each of those treatment types. So throughput per bed day, yes? And then we can say, take a simple ranking system and rank the patients from the highest throughput per bed day down to the lowest throughput per bed day. Now, what I'm not suggesting is this is the only criteria we use. If you remember, I said we need the backlog, the size of the backlog, we need the urgency of the care, and we need this financial criteria to help us establish the sequence of how we should work through the list. Yeah. And with those three criteria and talking to the clinical staff that are involved in actually carrying out the treatment, we can put together a very, very robust and simple plan which enables us to exploit that limiting factor, that constraint of bed availability, so that we can provide high quality, safe, rapid care to the ones who need it, but also be mindful of the throughput per bed day that we are able to get out of each of the various treatment types, yes? And we should remember that that throughput should be based on money we receive, yeah? There's no point in having a high throughput per bed day if we're never going to get the money, yes? It has to be based on realistic assumptions about where we're going to get the money. And then from those three perspectives, we can come up with our plan. Actually, a simple list, do these, then these, then these, yeah, and work our way through it.
So it's fundamentally what we would call a drum, basically the program of how we're going to process the patients based on the priority established by the criteria given first, the clinical
Yes.
and the medical considerations that are the key, but then without discarding or discounting that the throughput per constrained unit or the throughput per available bed day is
Yep.
very important, because we need the recovery of the hospital or the clinic to be financially viable, because we're talking about regaining the ability to pay people salary and compensation based on the work that they've been doing.
Exactly.
Because I think if I may make two comments, my interest in us having this discussion is because I see that we've had a very deep emotional sometimes dilemma that has been surfaced through this pandemic, which is, do we take care of health first or do we take care of the economy? And it seems to be at odds depending on who you talk to. And what we're proposing here is that there is a way, without losing the understanding that the health criteria is first and foremost, because you're actually dealing with sick people or people that need help to recover their health state or status. But then you cannot discard the economic side of it, because at the end, we need to generate the revenue in order to sustain the institutions viable.
You're absolutely right, Javier. So when somebody says to me, should we put health first or finances first? My answer is very simple. Yes, we need to put them both together to work out what to do. Yes, we have to meet those patients with the greatest need, but we also have to understand the financial impact on the system, because if the system collapses, then there won't be any treatment for anyone anyway. Yes. Wow. And particularly when we have staff who are obviously already exhausted, already tired, we need to make sure that we make the most out of that common resource, if you like, of the bed, the timing, and the staff. Now, you can tell things are getting better in the UK. I don't know whether you can hear, but an ice cream van has just come past my house. So obviously people can start to leave their houses now and go and get an ice cream. So I apologize about that.
No, that's okay. I think it shows the different stages of where our regions are. We in Latin America are still hunkered down and hoping for some flexibility. Also watching our big brother to the north that seems to be, tangled up in a real tug of war, trying to decide when to open and when to close, if coming back or not, with the resurgence of the contagion rate. At any event, I think one of the important things that I wanted to mention is, given the situation, because I think we assumed that everybody would understand, but I think the situation is, with all the COVID treatments that the institutions had to dedicate their time and efforts to with their staff, the reality is that everybody else decided, and obviously so, stayed away from the hospitals and to treat anything that, it takes time, or that it was programmed or scheduled. And even people, I think, are praying not to get sick of anything, just not to get close, to the door of any hospital or healthcare institution. And that clearly is part of the regular revenue that the hospitals and clinics are getting. Because right now, for example, here in Chile, many of the private clinics have been mandated by the government that they have to treat patients with the COVID contagion. Of course, insurance will come and all of this, but the revenue is not certain. And the level of expense is very, very high, because we're talking about a lot of hospitalizations requiring the intensive care involvement and all the respirators and all of the things. So it's the very high end of the expensive treatments that we're getting with these things. It's not just a regular hospitalization. So in this case, most of the people that had some ailment or condition are having just to wait. And we're talking about now at least half a year or more that people have been waiting and will continue to have to wait until the rate eases down, and then the hospitals and clinics can open up again some of the wards to start receiving the regular inflow of patients.
And you see, where you're absolutely right is because some of those illnesses require, the longer you wait for the treatment, the sicker you will become, or the more pain you will become. So obviously those ones we need to address very rapidly, yes? But if we are leaving this environment, basically what's happening is new capacity is starting to emerge, and we have a responsibility to make sure that we make the most of that capacity, yes? Now, what I'm suggesting to clients is actually, this is how to do it as we emerge, but actually it's a new way of always thinking about how to maximize the opportunity through our limited resources. Yes, that's the core of the theory of constraints approach. Yes, how do we take those limiting factors and get the most through that system by delivering the most towards the goal units? Now, in a hospital environment or a healthcare environment, those goal units are obviously measured in healthcare outcomes, but the system itself has to remain financially viable. Yes, so we cannot ignore one against the other. We have to look at both on the same page at the same time, and that can help us through. And in terms of getting started on this, actually it's very straightforward. You know, the data I've talked about is not difficult.
Yeah.
Everyone will have a list of their backlogs, yes, or a near enough list of their backlogs. They can look at their previous average length of stay, yes. If, for example, by the way, their throughput per bed day looks low, they could think about maybe that's an area to try and reduce their length of stay. But for the first calculation, throughput per bed day is good enough, yes?
Correct.
If they don't have information about the variable costs, just do sales price per bed day, yeah, as a first go at what this calculation's doing.
Correct.
The data's easy, the data's there. The real trick is then putting together the plan to make sure that we then get the most out of the system. And that should be a small team, combination of the finance, the doctors leading the process, and the management. Wouldn't it be lovely, all three in the same room, doctors, finance, and managers? Then we can sort it.
Yeah, that would be lovely. So I think the question that begs to be asked is, how do we help? How do we intervene? What can we offer any institution that desires to get some help or guidance on following this approach?
Well, the first thing, and a very simple thing to do, is guide them through the data analysis. Yes, we've done this many, many times. We know the tricks to do what data is important and how to get hold of it. So to come up with that stage quickly, yes. And my experience is if you have the right people helping you, you can do all the basic analysis in a week. Yes, 2 weeks at the absolute most. Yes, so now is the time to get on with it. Don't wait until you've got the free beds, yes, the free capacity. Do the calculations now, yes, and then you'll be ready for the way out. So that's the first thing. The second thing is in putting together the plan of recovery itself, yes, making sure that as you build that plan, you have the drum as you suggested, yes, which is beating the pace of the plan.
Correct.
And you make sure that you have everything else subordinated to it. So one plan with full subordination across all resources, yes. Then you can use that to do things like check for full kits, check for make sure you have all the necessary ingredients to deliver the plan, yes. So that's the second bit. And then the third piece, of course, is once you're up and running, the approach that's described in Pride&Joy can then be the way that you make sure there is no subsequent disruption or delay as those patients are then passing through the system. So that once we've got the free bed and we've got the patient in there, we then don't waste a day during their patient journey. And that's the whole principle of described in Pride&Joy.
So fundamentally, what I see is that the crisis has pushed many of us and many people, especially in the healthcare sector, to do away with policies and things that, you know, were part of the day-to-day, that were thought to be contributing to keeping the control and the flow of the processes. But nevertheless, this demanded faster response, quick decisions, and hopefully on the right track and to the right target. Having these emergencies usually force you to question the way things are normally done, and you end up speeding up the processes and learning and gaining insights that there's a faster way, a better way, a less complicated way to solve the issue of capacity, of attendance, and dealing with the day-to-day fluctuations, if you want. But as soon as the crisis starts to ease away, it's very common for us to say, I'm so glad this is going away. Now I can return back to normal, which is what you hear everywhere is we want to go back to normal, even though they're calling it the new normal. But I know deep down inside, we just wanted to go back to what it used to be, which is not going to happen. And I remember Ellie saying that in the situations of crisis, this is the time to learn what rules you broke, what rules you changed, because now think in terms of how can you apply them to the new reality or new normality in order to gain even better performance, better results, and ease some of the pains that the former way to operate contributed to.
Absolutely. So two simple examples, if you like, is I know hospitals that for many years have tried to get a more effective outpatient process going. Yes. And one of the steps that they've done is a physical change, which is where they've tried to get not all, but some of those done through video conferencing. Yes. And it's often taken years of discussions about whether it's going to work or not and whether the quality will go up. A doctor said to me recently who'd moved over to a video-based outpatient system, just like that, by the way, when the COVID crisis hit, just like that. He said, actually, Alex, I think I'm giving a better service to my patients. Yes. He still needs to bring some in for physical examination, etc. But for discussion, the patient doesn't have all the stress of getting to the hospital just for a 10-minute appointment or whatever. And actually, it's a much better conversation they have. So those are the sort of physical changes that have been happening.
Correct.
What we've also now seeing, what I'm proposing, is we need a similar approach with the logistical changes. We mustn't go back to running the hospital with the logistics systems we had in the past. We must use this opportunity to move towards a much more flow-orientated, constraints-based system of management. Yes, let's remember that very important phrase that Dr. Goldratt taught us. Balancing flow is entirely different from balancing capacity. Yes.
Correct.
And many of the old approaches of logistics were all about balancing capacity. What COVID teaches is what to break, policies to constraints to break to improve flow. Yes, because flow was dominant. Let's now ensure that flow remains dominant as we move out of this crisis. Yes?
Absolutely, absolutely. I agree in the full extent, and I think this is probably the biggest change that we can strive for in terms of the mindset and how to approach the performance and the administration of the resources within the healthcare system. So, Alex, just one final thought or question. It's going to take at least several months more for many of the countries to really, I think, gain control. So why do you think it's now the time to start gathering this data and planning this? My question relates also to the resources in terms of, I assume that the staff or the directors of the hospitals are being demanded a significant amount of time to make the decisions and to continue to deliver what they're to deliver, which is on the health of their patients. But at the same time, why do you think this is probably the right time or soon to be the right time to start planning these things?
So there are two main reasons. The first is we definitely want to do our homework now so that we can be in a good place to make the most of the capacity as it comes free. Yes?
Yes.
The second thing, and the important thing is the people we need to help us with this. Actually, they're people who are not heavily involved in the frontline activities at the moment. So it would be good to have somebody from the core IT area who are able to help us get the data we need, somebody from the finance department to help us with the throughput calculations, yes? And actually, if you think about the clinical engagement we're after, it's actually from that planned care stream. So the surgeons and the outpatients related resources, yeah, who are not actually that busy. Some of them have been redirected into the COVID, but other ones, do actually have the opportunity at the moment to do it. So I don't want to take one person away from the front line that's needed on the front line.
Correct.
But I think there are other resources that are available now that can help us with these calculations and the plan to get us started. And to be honest, my experience in hospitals is the rest of the staff are actually pleased to see the preparation and planning going on for the post-crisis period, yes? So that they know somebody is taking ownership and responsibility to get the ship back on track once this crisis is over. So I think we can do it without disturbing the front line.
Great. I wanted to make sure that we dispel properly of any reservations that might appear that said, you guys are crazy. How are you asking people to give you time when actually the crisis is still going on? But as you say, we are assuming that the critical resources that we will need in order to do the analysis and help in the planning actually would be people that would have the time and the space actually, and would be more than happy to dedicate some of their day to actually helping build this out and ensure a faster recovery for the hospital or the clinic. I think those are the questions I had and the discussion, so I really appreciate it. I don't know if you have any final thoughts. What I would do is I would make sure that this recording interaction between us goes in the proper way to the distribution channel so people are aware of what we've been thinking about, how to approach the current crisis, but at the same time, since this is going to pass sooner or later, depending on where you are in the world, we just wanted also to be prepared to contribute from our side and be ready to help.
Well, first of all, thank you very much for the opportunity to talk this through. And secondly, if anyone does have any questions or any reservations or any thoughts, then they know, please just contact either yourself or myself, and we look forward to helping them think those things through.
Thank you very much. So let's get it done.
Okay.
Thank you, Alex.
Very much, Javier.
Pleasure.